Hi, I'm Bonnie, and today I will be talking about yellow fever. Yellow fever is a hemorrhagic fever due to the infection of virus from the family of flaviridae. Flaviridae are small, single-stranded RNA viruses. Yellow fever is spherical in shape. It has a diameter of 40 to 60 nanometers, and the virus is an arbovirus of the Flavivirus genus. The pathogenesis of yellow fever is when a female mosquito bites and transmits an individual with 1,000 up to 100,000 viral particles. In the individual, the viral particles multiply in dendritic cells, which then spread to the lymph nodes. Primary replication of the virus occurs in the monocytes, macrophages, and large histiocytes. The virus spreads lymphatically, which tend to affect the liver and spleen and lymph nodes. Transmission of yellow fever involves mosquitoes. Mosquitoes are the vector for yellow fever, and different species of mosquitoes depend on which part of the world you are. Yellow fever virus has 3 transmission cycles: jungle, intermediate, and urban. The jungle cycle involves transmission of the virus between non-human primates, for instance monkeys, and mosquitoes found in the forest canopy. The virus is transmitted by mosquitoes from monkeys to humans when humans are visiting or working in the jungle. In Africa, an intermediate cycle exists that involves transmission of virus from mosquitoes to human living or working in the jungle border areas. In this cycle, the virus can be transmitted from monkey to human or from human to human via mosquitoes. The urban cycle involves transmission of the virus between humans and urban mosquitoes, primarily Aedes aegypti. The virus is usually brought to the urban setting by a vermic human who was infected by the jungle or savanna. 47 countries in Africa and Central and South America are either endemic for or have regions that are endemic for yellow fever. A modeling study based on Africa data, sources estimated the burden of yellow fever during 2013 was 84,000 to 170,000 severe cases, and about 29,000 to 60,000 deaths occurred from this outbreak. Occasionally, travelers who visit yellow fever endemic countries may bring the disease to countries free from yellow fever. In order to prevent such importation of the disease, many countries require proof of vaccination against yellow fever before they will issue a visa, particularly if travelers come from or have visited yellow fever endemic areas. In past countries, yellow fever was transported to North America and Europe, causing large outbreaks that disrupted economies, development, and in some cases, decimated populations. The yellow fever virus originated in Africa and was brought to the Western Hemisphere during the slave trade era, with the first epidemic reported in 1648 in the Yucatan. Over the ensuing 200 years, outbreaks occurred widely in tropical America and North American coastal cities and Europe. By the 19th century, it was recognized that yellow fever was not a communicable person-to-person virus, but theories wrongly attributed the disease to atmospheric. In 1881, Carlos Finley of Cuba significantly advanced the field when he suggested that Culex cubanus, also known as Aedes aegypti, as a mosquito responsible for spreading the disease. Despite multiple attempts, he was not able to prove his theory, but it would serve as a basis for Reed's research. At the end of the 19th century, the United States invaded Cuba during its war with Spain. For every soldier who died in battle, 13 died of yellow fever. Surgeon General George Sternberg sent Walter Reed, James Carl, and Jesse Lazard to Cuba to investigate the causes of yellow fever. Reed's work proved that Aedes aegypti mosquitoes were the primary mode of transmission of the disease, and that yellow fever was caused by an agent found in the blood of infected patients. One of the worst outbreaks of yellow fever in the United States occurred in 1973 and killed about 10% of Philadelphia's population. The last epidemic that occurred in the United States was in New Orleans in 1905. Max Teller started working on his research on yellow fever in 1930, and Teller and his colleagues attained a vaccine for yellow fever in 1936. Once contracted, yellow fever virus incubates in the body for 3 to 6 days. Many people do not experience symptoms, but when they do occur, the most common are fever, muscle pain with a prominent backache, headache, loss of appetite, and nausea or vomiting. In most cases, symptoms will disappear in 3 to 4 days. A smaller percent of patients will enter into a second and then third phase within 24 hours. High fever returns and several body systems are affected. With yellow fever, 3 phases are the most common. The first phase is infection. This is where you first experience the fever, chills, nausea, vomiting, and usually they improve within a week. If they don't improve within the week, that's when you enter the second phase, which is usually called remission. And severe symptoms of the second phase include high fever, jaundice, or bleeding. For most people, this is the phase where all their symptoms go away, but for others, it can worsen. Third phase is intoxication. This is where your body goes into shock and organ failure. Seizures and coma are also very common during this stage. After a person develops severe symptoms, the mortality rate increases significantly from 30 to 60% of people will die from yellow fever. Vaccination is the most important means of preventing yellow fever. Yellow fever vaccine is safe, affordable, and a single dose provides lifelong protection against yellow fever disease. A booster dose of yellow fever vaccine is not needed, but is sometimes necessary if a person is traveling to endemic areas. Several vaccination strategies are used to prevent yellow fever disease and transmission. Routine infant immunization, mass vaccination, campaigns designed to increase coverage in countries at risk, and vaccination of travelers going to yellow fever endemic areas. In high-risk areas where vaccination coverage is low, prompt recognition and control of outbreaks using mass immunization is critical. It is important to vaccinate most, 80% or more, of the population at risk to prevent transmission in a region with a yellow fever outbreak. There have been rare reports of serious side effects of the yellow fever vaccine. The rates for these severe adverse events following immunization, when the vaccine provokes, attack the liver, the kidneys, or the nervous systems, between 0 and 0.21 cases per 10,000 doses in regions where yellow fever is endemic, and from 0.09 to 0.4 cases per 10,000 doses in population not exposed to the virus. The risk of AEFI is higher for people over 60 years of age, and anyone with severe immunodeficiency due to symptoms of HIV or AIDS or other causes who have thymus disorders. People over the age of 60 should be given the vaccine after a careful risk-benefit assessment. People are usually excluded from the vaccination include infants ages 9 months or less, pregnant women except during a yellow fever outbreak when the risk of infection is high, people with severe allergies to egg protein, and people with severe immunodeficiency due to AIDS or other causes. In accordance with the international health regulations, countries have the right to require travelers to provide a certificate of yellow fever vaccination. If there are medical grounds for not getting vaccinated, this must be certified by the appropriate authorities. The IHR are legally binding framework to stop the spread of infectious disease and other health threats, requiring the certificate of vaccination from travelers at the discretion of each state and party is not currently required by all countries. Another way to prevent yellow fever is vector control. The risk of yellow fever transmission in urban areas can be reduced by eliminating potential mosquito breeding sites, including applying larvicides to water storage containers and other places where standing water collects. Both vector surveillance and controls are components of prevention and control of vector-borne disease, especially for the transmission control in endemic situations. For yellow fever, vector surveillance targeting Aedes aegypti and other Aedes species inform where the risk is of an urban outbreak. Understanding the distribution of these mosquitoes within a country can allow a country to prioritize areas to strengthen their human disease surveillance and testing, and to consider vector control activities. There is currently a limited public health arsenal of safe and efficient, cost-effective insecticides that can be used against adult vectors. This is mainly due to the resistance of major vectors to common insecticides and the withdrawal of abandonment of certain pesticides for reasons of safety or other high costs of re-registration. Historically, mosquito control campaigns successfully eliminated the Aedes aegypti, the urban yellow fever vector, from most of Central and South America. However, Aedes aegypti has recolonized urban areas and regions, raising a renewed risk of urban yellow fever. Mosquito control programs targeting wild mosquitoes in forested areas are not particular for preventing jungle or saladic yellow fever transmission. Personal prevention measures such as clothing, minimizing skin exposure, and repellents are recommended to avoid mosquito bites. The use of insecticide-treated bed nets is limited by the fact that the Aedes mosquito bite during the daytime. The treatment for yellow fever is pretty simple. The yellow fever vaccine has been available for over 80 years and is very effective. The vaccine is recommended for people 9 months or older, and only one dose is necessary for most. It is recommended that people living in high-risk areas receive the vaccine.